it starts off in stages. So mildly abnormal blood vessel growth is stage 1. And as the blood vessels grow, it causes the retina to detach from the back of the eye. Once the retina is completely detached, that's considered end stage of the disease, and I'm not sure that it can be reversed at that point. Prior to that, laser therapy can be done to make the retina reattach to the back of the eye. So treatment is laser ablation therapy and giving vitamin E to the infant. Do you want to add to your notes that laser ablation therapy will help the retina to reattach to the back of the eye? And also gets rid of the abnormal blood vessels. So laser ablation therapy will help the retina attach to the back of the eye. And also helps to get rid of abnormal blood vessels.
Is that abnormal? What did you say?
Abnormal blood vessels? It gets rid of abnormal blood vessels. So with preemies, we keep the O2 stats 85 to 92%. And it seems like every year that I lecture, the numbers have changed. I think in our next handout, I'll give you the current O2 ranges. I think they're doing 85 to 95 now. It's the high PaO2, not the FiO2, that causes the damage. And that will be a test question. Something like a premature infant is on 60% FiO2. This will cause ROP. And the answer is no. What causes the ROP is if the PaO2 is high, not the FiO2 that we're giving to the lungs.
Gotta pay attention.
Yeah. I mean, high FiO2s do cause damage to the lung tissue, but that's not what's causing the ROP. Before increasing FiO2, ensure that the patient is hypoxemic. Make sure that the pulse ox is on, they're not crying and moving around, you're getting abnormal readings. Use an O2 and air blender so you can give small increments of increased FiO2s. 2 and 3? What happened to number 1?
I think we did.
ROP results in the detachment of A, the cornea, B, the retina, C, the fovea, or D, the macula?
B, the retina.
B, the retina. ROP affects premature neonates and full-term neonates, true or false?
False. Only.
Treatment to reverse effects of ROP consists of A, laser ablation of the affected vascular area, administration of vitamin E and limiting light exposure, careful use of supplemental oxygen, none of the above, or all of the above?
All of the above?
Yes, all of the above.
So careful use of supplemental oxygen can reverse that?
All right, I see your point.
I thought maybe it could prevent it, but not reverse it.
You're right. It's not a good question then. Okay, so.
A and B without.
Treatment slash prevention of ROP consists of, how would that be? Did I skip something?
Mm-mm.
Okay, it's just the slides got moved around a little bit. All right, let's talk let's talk about air leak syndromes. All right, so looking at somebody on positive pressure, what can happen is when we're delivering positive pressure to newborn lungs, especially with premature infants, the lungs are really fragile, and alveoli can pop and air can start migrating from just in the conducting airways and alveoli into the interstitial spaces. It can get into the pleural space. It can actually migrate to the heart and get into the pericardial sac. So this shows some of the air leak syndromes. Do you recognize the pneumothorax?
Yes.
Doesn't this look like a bell?
It does.
That's
yeah.
collapsed lung tissue
Yeah.
from all the air
That's
around
what I
it.
heard.
Everything is shifted over to the right. I see the carina way over here. And what is this air for? Can you tell by looking at it what it is?
Air in the pleural space.
Yeah, so air around the heart or
Oh,
pneumopericardium.
pneumopericardium.
All right, so why do we get air leak syndromes? It's because of overdistension of the airways. Even if we're careful with our pressures, we can have uneven alveolar ventilation where you have some areas of the lung that are atelectatic and other areas are getting a lot more than they should because all the rest of the lung tissue is atelectatic. So it kind of forces too much air into the good areas and they become overdistended. So if a baby's on a ventilator and they get a pneumothorax, chest tubes needs to be put in right away. Reduce peak pressure in PEEP to allow the lung tissue to heal. Placing the FiO2 on 100% is supposedly good for helping the air that's in the pleural space to reabsorb because oxygen can get absorbed more easily than room air. And how do you diagnose whether there's been a pneumothorax? We talked about that. Do you know what transillumination is?
Yes.
Where's the, like, under
It's
the
just a
flashlight?
It's a way to test for pneumo.
Hyperlucency is pneumo.
Hyperlucent is a pneumo. Very good. And what is normal?
Translucent.
Translucent. Okay, symptoms of having too much air in the thorax from a pneumothorax or pneumomediastinum. You'll hear diminished breath sounds. When you do percussion, it'll be hyperresonant. Do you know what that means?
Maybe louder than usual.
It'll sound like an empty barrel. Very good. Because blood pressure will be low from all that pressure, you'll notice an increase in the heart rate to make up for the cardiac output. Something else that can happen is pulmonary interstitial emphysema. This is when air gets into the interstitial spaces and it diffuses throughout. So you see this grainy appearance of the x-ray on a baby that has pulmonary interstitial emphysema. There's a lot of air in the interstitial spaces of the lung and it gives that grainy looking appearance. Babies like this do best on high frequency ventilation where you're not delivering a positive pressure of 20 centimeters to the airway, you're delivering really small pressures and that allows the ruptured tissue to heal better. So, treatment for air leak syndromes, especially PIE, make sure you mention high frequency ventilation. So pneumomediastinum, air in the mediastinum. I don't really see it on this x-ray.
Yeah, I don't see it, no.
I can see some air around the heart. Maybe that's the way, the telltale sign.
Probably.
Maybe up in here. So air in the mediastinum. A pneumopericardium, I thought we saw this one already. We see air in the pericardial sac. Choose all that apply. What can be caused by air leaks in infants? Can you get subcutaneous emphysema?
It's D.
Yes, the
Opposite.
4 only.
It's 4 only? Good job. Something with a P.
Yeah, one of those. Yeah, C.
So
Wait.
1 and 2,
Yeah.
C. How would you treat a symptomatic infant on a ventilator with a tension pneumo?
Oh, chest tube, yeah.
Call Scott and ask him.
Choanal Atresia. Do I have this in my notes?
What? Choanal Atresia. Oh, it is, yeah. It's the last page.
Oh, okay. All right, so babies breathe through their nose only because their tongue is really large in their mouth. So if they get a stuffy nose, the only way they can really breathe through their nose is if they start crying. So typically, infants that have a cold or any inflammation in the nose, they cry a lot because that's how they're going to get their air. Well, what if they're born with an anomaly where the nose is occluded? And that can happen, and that's called choanal atresia. It can be just unilateral, where one side is blocked off, or it could be bilateral, where both sides are blocked off. And now the only way they're going to get air is if they start crying. So they cry, O2 sats come up, and then they stop crying, their airway obstructs,
Oh, no.
and then they're set, O2 sats fall, and then they start crying again, O2 sats go up.
There's no surgical procedure just to open
Yes.
that? Oh, okay.
So they need to have insertion of an oral airway if it's unilateral, or if it's bilateral, yeah, they need an airway. They need to be intubated until a surgical opening can be placed.
Wow.